hashtag GuruvarKaGyaan on the topic current trends in knee pain management with Dr. Anchit Uppal in association with Max Hospital, Saket. Dr. Anchit is a well-known doctor, specializes in orthopedic, and he has an experience over 14 years in various hospitals and clinics. Dr. Anchit Uppal specializes in hip pain management, knee care, chronic pain treatment, arthritis management, joint pain treatment, disc slip. So, without the further delay, I would like to now pass on the virtual stage to Dr. Anchit.
Good evening, everyone. Without wasting any further time, we would like to start with the presentation on recent advances in knee replacement. Am I audible to everybody? I just wanted to get a feedback
Yes,
if it's
yes, sir.
all
You are
audible.
perfectly.
Yeah,
Yes, sir.
yeah. So let's start with the presentation then. So I've been working with Max for past few years, and now joint replacement has become the notion of the day for patients who have pain. And the objective of knee replacement is basically to have pain relief, have a stable and functional joint with a good range of movement, and to restore biomechanics. Basically, to restore the axis of the limb so that whatever malalignment or deformity you have before the surgery, that gets corrected. And it's never too late for a new beginning, because we had one of our patients which was 91-year-old female, and she was very happy after her surgery of knee replacement. So basically, before starting with knee replacement, why knee replacement is required and when it is required. So basically, you need to understand a difference between what is osteoarthritis and what is osteoporosis. Osteoarthritis is basically the degenerative processes that happen with aging in the knee. On the left knee, you could see that there is deformity of the knee. That means there is bending of the knee, which happens with aging. Naturally, we have a cartilage covering over the knee, which as we grow older, that cartilage gets eroded and the bone surface gets exposed, which gets rubbed against the opposite side of the bone, and you tend to get pain, which is called osteoarthritis. While osteoporosis is disease of the bone, wherein the bone quality becomes poor, which you see on the right side, the bone quality is poor, which are more prone to fractures. So that is the basic difference between osteoporosis and osteoarthritis. So, what is our motto with knee replacement? To get a proper alignment, what I was talking about biomechanical is from a deformed knee to a straight knee. And sometimes we do require, normally the implants are short stemmed in the lower shin bone, which we call as tibia, and in the femur, which we call the upper thigh bone. But sometimes, as you can see the arrow mark, sometimes when you have osteoporosis or you present late to us, that time we have to use a implant which has a longer stem or a rod which goes in to your shin bone so that we can support the implant properly. Normally, this is the type of X-ray we anticipate post-operatively, wherein the patient has pre-operatively arthritis. Arthritis, basically this, if you can see the arrow, this is the thigh bone, this is the shin bone. Between the bones, there is no space left. Basically, this is arthritis, wherein the bone starts rubbing against each other and you tend to get pains, which is managed by knee replacement. So normally the trend today is after surgery, the patients are mobilized, full weight bearing with the help of walker within 6 hours after the surgery, because we use patient specific analgesia, which is basically pain management after the surgery. So once the patient is comfortable enough, they start walking with the support after 6 hours, and this is the same patient after 6 weeks walking without any support. So basically, what are now the advances in knee replacement? If I say, we can categorize it into three subsets: the implants, the surgical techniques, and the gadgets. So, implants over the long run haven't changed much over the past 30 years, but there has been a journey of implants from high flex knee to gender knee, energy, various implants are available. High flex knees are ones wherein you get more mobility in the knee joint and you are able to bend your knee more. But as such, high flex knee is not the answer to get your knee bent more. It all depends on pre-operatively how much you had the knee range of movement. Post-operatively, the range of movement improves slightly more than what you had pre-operatively. None of the implants can improve your range of movement which was present pre-operatively. So a recent new advance was oxenium knee, which was introduced, say, around 12 years ago, wherein normally we have alloy of chromium cobalt molybdenum, which was converted and oxidized zirconium metal was overlaid over the chromium cobalt to give a superior bearing surface. But as of date, Energy X3 from the Striker has the longest survivorship and the largest series till date. X3 is the polyethylene between the two metallic parts which are implanted on the femur and the tibia, or the shin bone, or the and the thigh bone, and this is multiple times annealed, so that has a longer survivorship. So the future here is today. It's basically what recent advance has been made is X3 poly and vitamin E poly, wherein the doping has been done so that it has longer life. And latest implants now are the Persona knee, Attune knee, Triathlon, and the very last knee. So very last knee is a 30 years old knee. Oxenium, as I just told you, it has superior bearing surface. So this is oxenium knee, which looks black in color. So yes, coming to what surgical techniques, what are the recent advances in surgical techniques? Now we are using minimally invasive techniques so that we have less blood loss and the patient can be mobilized very early. And we use submuscular or the subvastus approach. And wherein the incision initially you can see were around 10 inches long, now the surgical scars are very, very small in minimally invasive surgery, even in fatty and obese patients. And initially, the sutures which were put were mainly on the outside, which had to be removed. Now we use dissolvable sutures, and the stitch line is very, very neat and clean. And these are the various approaches what we use. So coming to gadgets or technology, what has been in the recent advances is now there has been a recent upsurge in patient specific instrumentation, navigation or computer assisted surgery, and robotics or robot assisted arm. So what basically is patient specific instrumentation? It's basically the implant is the same. Whatever normally is used for any person, that same implant can be used for you as well, but it is an alternative to computer navigation, wherein it's just the blocks for cutting your bone or the articular surface are used, so that you get a customized cutting of the bone, but the implant is same. It just reduces our operating time and may reduce the cost in long run. They are at present expensive because they are CAD CAM designed, requires X-ray and MRI, which needs to be sent to the lab, and cutting blocks are received, a long time taking process of around 3 weeks. So what we usually do is computer navigation, wherein trackers are around placed around the knee. It is more precise. We get a better and perfect alignment, which leads to less blood loss, less pain, better and early rehabilitation. So that we get a proper cuts. These are what we aim at putting the implant. Before putting the implant, we take cuts so that we get a proper cut of the bone surface so that implant is placed in proper position. What we usually use here at Max Saket is a pinless system, a NAB3 by Striker, which does not require pins to be placed outside the joint surface. It's just on the surface of the joint wherein pins are placed, and we do the optimized cuts so that your bone is cut minimally and alignment is perfect so that we get a perfect result post operatively. So the difference between PSI, because lots of patients when they come they want patient specific instrumentation. They think PSI is patient specific instrumentation. On the other hand, it's patient specific implants, what they are told. So there's no virtual difference between the two. So this is how we get the resection cut for the thigh bone with the navigation instrumentation. So robotics has been in vogue since 2006, and in India recently it has come. Striker has come with Mako, and now with this we get accurate planning for implant sizes, orientation, and alignment preoperatively. And intraoperatively also we can do the adjustment. You need to understand that robotics is just a robotic arm wherein it helps in removing the articular surface, but rest of the surgery needs to be done by the surgeon himself, of dealing with how much bone needs to be cut, how the implant has to be placed. It is just the robotic arm that helps in accurately cutting the surfaces. So coming to rehabilitation, it's early mobilization as early as possible. The same day of surgery, 6 hours post-operatively, we do that, and we do not stop the patients from anything, including stairs. Physiotherapy has to be under supervision of trained physiotherapists, and ice fermentation we recommend to reduce the inflammation and reduce pain every 3 to 5 hours for 10 to 15 minutes. So this is the set of protocol we follow after the surgery. One of our patients who was doing full knee bending after 6 weeks after surgery. This is another patient around 6 weeks after surgery. Though we tell the patients not to sit or squat, but most of the patients who come from a poor socioeconomic background wherein they have to use Indian toilet for their daily chores, they usually do squatting as well. And she is a dancer, renowned Bharatnatyam dancer, who on the second post-op day started stair climbing as well. Another of our patients, third day, stair climbing. So we do not restrict our patients from doing stair climbing. This is one of our patients who herself is a gynecologist, and her whole family is into professional cycling. She had her knee replacement, and after 3 months, this is her doing her cycling activities. This is one of our international patients, though we tell the patients not to kneel down, but due to their religious restrictions, they do all the activities. And she had a drastic weight reduction from 120 kgs to 85 kgs in a duration of 6 months, because you need to understand that it is a vicious cycle wherein, because you have lot of pain in the knee, you are unable to walk, which causes increase in your weight gain again puts pressure on the knee, abnormal loading of the knee, which again causes lot of knee pain. Hence it forms a vicious cycle which needs to be broken, probably with the help of a knee replacement surgery. Few of our patients who are happy walking around the second day of surgery. This is after 6 weeks. You can see the amount of knee bending. This is 6 weeks after surgery. Sorry, the video isn't playing. That's it. Thank you from my side. Would be happy to answer the questions.
Thank you so much, sir, for sharing your insights on the topic. And now we have few questions from the audience, so I'll just ask them.
Yes.
So my first question is, whenever any patient is going for such a surgery, which company's implants do you use at Max Hospital?
See, we do not go with a fixed pre-mind that we have to use this implant only. We have an array of implants, and it is the patient's specific size which we see intraoperatively is required. We use the same size of implant that the patient specifically requires. One. Second, coming to the company, all three brands are available which are manufactured in US, either it's Striker or Depu J&J, or uh, we usually use this thing Striker and Depu.
Okay. So, sir, my next question is there any kind of risk involved in the surgery?
See, all surgeries come with their own share of risks, but if the surgery is done in a supervised environment like in a hospital like Max, where you have a controlled environment, the risks of surgery are minimal, very minimal.
Okay. So, sir, my last question is how long does the patient has to stay in the hospital before getting like discharge?
Normally, the current practice, what we are doing is on the day of surgery, we make the patient mobilize with the help of walker. So when the patient is comfortable enough, first day we keep him in monitoring in ICU, and the subsequent day he she is shifted to the ward. The patient stays in the ward for around 1 to 2 days post-operatively. If everything is fine, the third post-operative day, we generally tend to discharge the patient.
Okay.
So it's a roughly a stay of 3 to 4 days. If both knees are replaced simultaneously, if a single knee is replaced one at a time, so we generally keep the patient in the hospital for 2 days.
Okay. So, sir, that's all from our side.
Yeah. Thank you.